Good morning, everyone. This is Ellen Barra from the WPS GHA Provider Outreach and Education Department. What we are going to be talking about today is chronic care management, the care planning section of this service you can provide to your patient. Just a couple of housekeeping things that we want to go through before we get started. You can listen to this through through your computer system, through WebEx itself. You can also, if you don't have audio through your computer, you can use the WebEx function to either have a dial-in number or they can call you back, whichever you prefer. All of our questions will be through the chat function. We will have someone monitoring that, and then we will go through those questions at the end of our experience today. One of our modules that we have in this course is to provides you a link to take a survey. We really encourage you to take that survey. CMS evaluates the survey numbers for our events and then also the responses. Unfortunately, however, the number of our attendees taking surveys has dropped considerably, and CMS notices that. So please take the survey. We also have a post-assessment that you'll need to complete before you can be given credit for this course. In addition to that, there is information there through, I'm sorry, I can't talk this morning. Through the modules, there's also a follow-up question module. So if there's any questions that we did not get to today on the call itself, then you'll be able to submit your questions through there. We will be updating our Q&A document that we have as an asset within our Learning Center following this presentation, and then we will publish when we get that document completed with adding the questions from today's webinar into the document. The last thing that I want you to know also is that in order to mark you as complete for this course, you do have to stay on for the entire time. And that does include any question and answer time that we have at the end. This webinar is scheduled for an hour and a half, and it will end either at 11:30, or if we get through all the questions in the presentation, it will end prior to that. This slide that we have up is just a disclaimer and just tells you that the information we have for you today is as accurate as we can make it. Medicare rules do change often, and the final CMS publications and the rules and regulations published by CMS are the final determinant as to coverage. And then, of course, your documentation is a big part of that. So before we go into the presentation itself, I want to introduce you to one of our new contractor medical directors. Dr. Joelle Vahakas is kind of overseeing the chronic care management services, and she's going to talk to us about CCM a little bit. So Dr. Vahakas, I'll turn it over to you.
Thank you, Ellen. So I'm Joelle. I'm an internist and a pediatrician who's now found herself doing some very interesting work for WPS and really hoping to increase the usage of this very relevant and very beneficial program of chronic care management. First of all, I just want you all to know that what you and your teams do, your clinical teams and your providers do for your patients is nothing short of heroic. It's really extraordinary that anyone is able to manage chronic conditions with all the complexities that you have and all the challenges. It's also certainly heroic to be a patient with more than one chronic illness to manage. I think all of us are aware between patients and families that we help along the way that it is sometimes a full-time job to be a patient. The thing about chronic care management is that even though it's challenging to implement, what we know are there incredible rewards to this, both for the patients, which we expect and we hope for, but also for the providers. Um, Doctors and our clinicians who are able to do this successfully have uniformly told us that it's really a great way for them to connect with patients in a very different way. I think of all the tools and aspects of chronic care management, this, the care planning, is probably the single most important and tangible driver of what makes this program work. And if you think about it, it's really an entirely different approach to care. And that's why it feels so monumental and so challenging in a way. As a physician, much of my training was learning to manage the most difficult patients in crisis, right? It was really a reactive practice that I learned, especially in my early training. This is a proactive approach to patients. And I think that's really where CCM and its power lies. It's really designed to get people out of crisis mode. And I say people because that means both the clinicians and the patients and their families, and really focus more on that quality of life mode. I want to just mention too that there are tools to help you, and we can talk about that in the Q&A. I've been especially keen to try to find these for myself, trying to figure out, what's the secret sauce here? What is it that we can do to help you in a tangible way so that you can use CCM successfully in your practices? I think step one is attending these sessions, and I just want to congratulate you for finding it. Ellen and her team, they do an excellent job, an outstanding job. The amount of thought they put into these programs is really extraordinary. And I know that you're going to get a lot of benefit out of it. So I'm going to hand it over to Ellen and her team and let her really tell you what's so great about care planning.
All right, thank you, Dr. Vlahakis. We appreciate that. Let me slide down again on our slide deck. So what is our objective for the goal of this presentation really is to provide you with education on what are the CMS requirements for the care plan, what type of information needs to be included in with that. Um, we'll talk about some of those different items as we go through the presentation itself. We know based on some of our pre-assessment questions that there is some confusion out there on what needs to be in the care plan, and we'll kind of talk about that as we go through. So on your handout, it shows you what we're going to cover today. We're going to provide just a very brief overview of CCM itself. We have an Encore presentation available that's in our Learning Center. This is from a presentation we did back in September. We also have a YouTube video out there, and then of course we have the question and answers. We're going to talk about the fact that this is a patient-centered plan. So it's not only the chronic conditions. CCM requires a patient to have at least 2 chronic conditions, and I'll show that in a second. But as Dr. Vlahakis said, it's really everything that's going on with the patient. When you're providing CCM patients, you're really the coach. So you're watching kind of everything that's going on. You're not necessarily treating everything, but you're watching everything that's going on and making sure it's cohesive for that patient, making sure that treatments and medications and things like that are not working against each other. And then the care plan is really vital for CCM services. It determines what's going to happen with that patient. It alerts others to problems that the patient may be facing, and it provides instructions for the clinical staff, who are generally the ones who are providing CCM services. But then it also alerts and provides information to other providers that are involved in that patient care. So, an overview of chronic care management, and chronic care management is kind of the umbrella under which CCM, chronic care management, CCCM, complex chronic care management, or PCM, principal care management, falls. So that can get a little confusing in the fact that CMS uses the term chronic care management both to encompass all three of the specific services and then also one of those services. So a patient is eligible for chronic care management if they have two or more chronic conditions. The condition is the conditions are expected to last at least 12 months or until the death of the patient. And these conditions place the patient at high risk of death, acute exacerbation, functional decline. As Dr. Vlahakis talked about earlier, CCM is really taking a different look at treating this patient. So she mentioned the fact that you don't have to have a patient in crisis. CCM is really working toward preventing the crisis, preventing emergency department visits, preventing additional hospitalizations, preventing those urgently needed office visits where you're having to work patients in. So, you know, that's the requirements for the chronic care management and complex chronic care management. The CMS Medicare Learning Network document on chronic care management services has a list of examples of what are considered chronic conditions. This list, however, is not all inclusive. It just has to meet the definition, expected to last at least 12 months or until the death of the patient. And if that condition or those conditions is not treated and taken care of, then it places that patient at significant risk. Doesn't mean your patient has to be in crisis today, but doing the care planning and doing CCM will help prevent those crises. For principal care management, this is a single high-risk condition. And so what we're looking at here, the patient is expected to have this at least 3 months or until death, and it places the patient at risk of crisis, or the patient has just had a crisis. And so now the specialist is going to be treating whatever that single high-risk condition is. And I use the term specialist. However, it can also be a primary care practitioner who is doing PCM. Generally speaking, primary care providers are going to be doing CCM or CCCM. Specialists are doing principal care management, but that's not a requirement by CMS. For principal care management, again, the patient has had some type of an exacerbation. They had a hospitalization, and now we need to stabilize that single high risk condition, or the patient is at great risk of a hospitalization or some type of exacerbation. So we want to work in order to prevent that if at all possible. Care planning is applicable to both of these services. If you have a patient who is receiving both chronic care management or principal care management, a patient can receive both, but you want to make sure that those practitioners are talking to each other. that the care planning then is encompassing everything that is going along with that particular patient. In addition to that, as part of CCM, the patient has to have 24/7 access to that clinical staff. And so what we mean by that is that, 3 o'clock in the morning, the patient wakes up and they're having some type of a problem. They have access to either your practitioner or your clinical staff, and that's determined by how you want to set that up within your office so that they can ask those questions. They can say, how this is going on with me, what do I do now? And hopefully then prevent them having to go to the emergency room. And CCM and PCM services are generally non-face-to-face. You can have face-to-face services that go along with that, but that's your choice. Generally, they are non-face-to-face services and they are provided on a monthly basis to that patient. CMS has been pretty clear in that this is a monthly service. It's not a 30-day service or a 90-day service, which is one of the things they proposed back in 2014, but it's a monthly service. So that means that we would expect this to be billed only once a month. Patients cannot have both CCM and CCCM in the same month. They can have CCM and PCM done by different providers within the same month. But what we would expect, and really your best practice, is to bill at the end of the month. That way you're catching all of the time that you are providing to your patient. For CCCM, there is a medical decision-making component. You want to make sure that you're capturing that, meaning that you can build that higher level code rather than the other one. But Medicare will not pay if the services are billed more than once in a 30-day time frame. So now let's get into care plan itself. There are two requirements for the care plan. Number one, it has to be patient-centered, which means that it's going to encompass kind of everything that is going on with that patient. Again, as I stated earlier, doesn't mean that you're necessarily treating everything. Another practitioner could be treating a problem, or the patient could have a problem that no one's treating. The care plan has to encompass all of those types of things. You can use templates if you choose to. CMS does not have any type of template that we can provide to you. As Dr. Vlahakis mentioned earlier, she's been researching some of the templates that are out there. Your medical societies, either national or local, could have provided a template for you. And then also in your handout, we have the TMF Networks. This is a quality improvement network or quality improvement organization. This is a CMS contracted company that looks for improvement in quality of care and then also innovations. They do provide an example of a template that you can use, and it is free if you choose to use it. But if you're using templates, you want to make sure that you can adjust those for each patient. So, and what I mean by that is if you have a patient, let's say one of their chronic conditions is diabetes, you don't want to have a template that is, number one, only for that diagnosis, because again, we have to have two. But each patient is going to be different. Each patient is going to have different needs, possibly different practitioners involved, other problems going along with the chronic conditions. So you just want to make sure that whatever template you're using, you can adjust that for your patient to encompass everything that is going along with your patient. In addition to that, the care plan needs to be electronic. Now, there is certain information that has to be captured in what CMS considers to be a certified electronic health record. And this is under the EHR incentive program, and it's whatever was the latest version of that certified program prior to the year that you're doing service. So for example, we're in 2022. So whatever was the certified program as of the end of 2021, that's the certified program. For 2021, it was actually a 2014 version that is the latest certified version that CMS says you have to use. I believe in the final rule, they are now moving to a 2015, but that won't happen until 2023. So you just want to make sure you're using the correct version. On your handout, it tells you what has to be captured through that certified system, and that's your patient demographics, all of the patient's problems, and then their medications and any allergies. That has to be in that certified system. The rest of your care planning does need to be electronic, but it doesn't have to go into that certified system. You need to have it in an electronic format so that you can share it. You're going to provide a copy of the care plan to the patient, and we'll talk about that in a second. You want to make sure that your clinical staff who are providing this care to your patients, that they have a copy of that. If your patient has other providers involved in that care, you need to be sharing a copy of that care plan with them. This would be providers both within your practice and also outside of your practice. So let's talk about the contents of the plan itself. Well, the first thing that we have listed there is the problem list. And again, this is everything that is going on with that particular patient. So that means it's going to include the 2 chronic conditions that are a requirement for CCM. It's also going to include any additional problems that you're treating. It's going to include any problems that other practitioners may be treating for the patient. And then it's going to include things that maybe no one's treating right at the moment. Maybe it hasn't escalated to that, but it is considered a problem for the patient. Um, when I was preparing for this webinar today and thinking about problems, one of the first examples that came into my mind concerning this was toenails. Now, you have patients who, have actual problems with toenails, and they could be being treated by a podiatrist, by their general practitioner. But you also have patients where maybe it hasn't escalated to that point, and identifying it as a problem, identifying what either the patient can be doing or what other treatment can be doing. That's where we're doing that proactive action as opposed to waiting until it becomes a crisis. I'm sure those of you that have elderly grandparents or elderly parents, or other people that may just not kind of take care of their toenails, have seen that person take their shoes off, and you look at their toenails and you go, "Oh my goodness, how can they walk?" You know, so that's one of the things that you would include, even though no one is necessarily treating it. So you would evaluate, is it what is going on with that problem? Is it causing them trouble with ambulation? Could it be a situation where the nails are pressing into the other toes? They haven't cut into the toes yet, but we want to prevent that. So that's the type of things that you'll be including within your problem list. And again, it's going to be everything that's going on with that patient, whether you're treating or not. The next one is the prognosis. So this is going to be the expected outcome or results, I guess you could say, of the problem that you're talking about. Sorry, my slide moved here. And so that's information that you'll provide to the patient. The outcome of this, we are talking about diabetes as an example. So our prognosis information could be, prognosis looks good if you stick to your diet, if you stick to your exercise. The outcome of this diabetes, if you don't do those, could result in amputations, it could result in dialysis, it could result in death. So for each of the problems you're identifying, you'll identify the outcome and prognosis. You also want to have measurable treatment goals. Again, if we go back to our example of diabetes, this is going to be the patient's blood sugars, either an A1C or a daily blood sugar. So what do you want to happen, and when do you want that to happen? In addition to that, part of the goals is going to be the instructions that you're providing to your patient. We want your A1C to be less than 6. Here's what we're going to do, but here's what you're going to do. We want you to include more fruit in your diet. We want you to increase your activity by 15 minutes a day or whatever the situation is. In addition to that, with this measurable treatment goals, you could also be including some remote monitoring services. Just an FYI for you, you can't bill for both. You can either bill for your remote therapeutic or remote patient monitoring procedure codes, or you can include the time that you're spending on that into your CCM, but you don't bill those separately. And then the next one on there is cognitive assessment. So this can include a wide variety of things. Number one, if you're talking with that patient, you're not identifying any type of cognitive dysfunction, then you can use your clinical judgment and you can stop there. If the patient is experiencing some cognitive dysfunction, if the caregiver is able to provide you or provides you with some information on a cognitive dysfunction, then you may look to do cognitive testing. But it is based on your clinical judgment. If you're talking to the patient and you don't identify any cognitive problems at all, then you don't have to go on and do testing. So additional things that we need to include in the plan. This is going to be functional limitations. This could be activities of daily living. Are they able to bathe themselves? Are they able to ambulate without, any type of assistance? If they're using assistance such as a walker or a cane, you would want to identify that. If they need help bathing, cooking, whatever the situation is. Um, there are, some testing things that you can look at, some different tests available out there. Again, that's based on the clinical judgment of the practitioner or the clinical staff as to whether or not that actual testing needs to take place. We also then have to identify system management. Again, this goes back to what problems do we have? Does the patient have? What symptoms are they experiencing with those? And again, we'll go back to that example of the toenails. They can't wear their shoes. They're having trouble ambulating. And then we're going to figure out what we do with that. So in the case of the toenails, it could be Depending on the situation that you have, a referral to a podiatrist. Medicare can cover podiatry services for patients dealing with toenails and cutting nails, especially under certain circumstances. And other circumstances that may not be covered. But you want to look at whatever symptoms they're having, and then how are we going to address those? Patient is short of breath. Well, how can we address that? Can we increase their activity to kind of increase their lung function, whatever the clinical determination is? And then we have planned interventions. Planned interventions includes quite a few different things. Number one, this would be any preventive services that the patient is eligible for. So this could be reminding the patient that they need to come and have their annual wellness visit, and it is due in September. They need to have their mammogram done, or it's time for a colonoscopy, any of those preventive services that Medicare has available. Planned interventions, though, can also include other things. Testing that you're going to do for the patient. You want the patient to have a monthly INR test. Another physician who is treating the patient wants them to have a kidney function test every 6 months. So those are the interventions that we're talking about. This can also include any surgical procedures, that are planned for that patient. And then we have medication management. Medication management is going to be real important in the fact that, especially if a patient has a lot of different providers involved in their care, or they have had a recent hospitalization, there could be a lot of different medications that the patient is on. And so, as part of the plan, you'll be looking at all of those medications. Are they all appropriate for the patient and the problems that they're experiencing? Are there medications that are working against each other? Are there medications that are causing additional symptoms or side effects? And then it's working to determine what is best for that patient. Now, if you're a family practitioner, for an example, and you're doing this, and you have other physicians also involved in that patient care, then you want to be having those conversations with them in order to make a determination. The patient's on medication X and it's causing this side effect. Could we switch them to medication Y, which hopefully would take care of the same problem, but may not have as many side effects? So that's part of what you would be doing there. Again, you're not necessarily going to, throw everything out and make the determinations yourself if there's other practitioners involved, but you want to have those conversations. The next part of the plan then is going to be an environmental evaluation. Now, part of this is going to be the safety needs in their home. Do they have pets, stairs, throw rugs, that type of stuff that the patient could trip over? I own a black dog, and she decided to stop in the middle of a hallway the other day, and I tripped over her and almost went down. So those are the types of things that you need to be looking for. You also want to look at their housing needs. Do they have some place to live? That's part of the social determinants of health, identifying patients who, because of social, restrictions or problems that they may be having, they can't necessarily implement what you want them to do as part of that plan. You also want to look at their safety from other people that are in their home. Do they have a caregiver living with them, or a son or a daughter or niece or something like that? Are they safe from them? Um, can they trust that that person is not going to steal their medications or something? So these are just kind of questions that you'll be asking. And then also, as part of that, depending on the answer that you get back, then you can adjust the plan going forward. One of the questions that you could ask, it's not required obviously, but that you could ask is whether they own their home or whether they're renting. If they own their home, can they make any needed repairs? If they're renting from someone, does that person who they're renting from, do they take care of any needed repairs so that they have heat, they have air conditioning, they have running water, etc. Um, One of the providers that we have talked to or asked a question on one of our previous webinars um, was, can we count time if we actually send someone to the patient's home in order to do this environmental assessment? Um, and the answer to that is yes. That's not going to be very common, but for that particular patient, they really believed that they needed to see the situation under which the patient was living in order to help them with that plan. So again, it is something you can do. If the next thing then is caregiver assessment, you want to look, first question, of course, is going to be, does the patient have a caregiver? And then the second is, does the patient need a caregiver? If they don't have one, if they don't need one, then, you're kind of done with the situation. If they need one or they have one, then you want to be looking at the physical capabilities of that caregiver, the mental capabilities of that caregiver. Um, can you provide instructions to that caregiver and will they understand that? Do you have a 6'1", 200-pound husband and the 5'1", 100-pound, soaking wet wife is trying to take care of him? Can they physically do that? If not, then you need to further develop that. What are other options for that patient? What are things that can be done in order to help that caregiver actually take care of the patient? Um, you want to be talking about interactions with outside providers. So this could be other practitioners, which we have talked about. It could be other providers, such as the hospital, the emergency department, urgent care facilities, skilled nursing homes, etc. Do you have a relationship with them? And when the patient tells you, hey, I had to go to the emergency room on Friday, can you get the information from that emergency care service so that you can then incorporate any information from that you need to within your plan of care? Another thing that you want to look at is community resources. We talked about environment. Does the patient actually have a place to live? Um, is it safe for them? Does it have heat, air conditioning, water, whatever the situation is? If not, then you want to be looking to your community resources in order to identify social agencies that may be able to help that patient. Nutritional needs, that can be the same thing. Do you need to get the patient signed up for Meals on Wheels, as an example? Are there other social agencies that have food pantries or churches within your areas that have food pantries so that the patient can get the amount of food that they really need? One of the things that happens with our Medicare beneficiaries, and especially, coming out of this public health emergency, is isolation. Family members live away. Maybe they're not able to drive or they didn't want to get out, because of the fear of COVID. So what are things that can be done concerning that. Again, maybe there's a senior citizen center within your area that plays bingo on Friday mornings. That's a suggestion that you could make to your patient. Um, there's all kinds of different social agencies and social activities and things like that that the patient could be involved in. You also want to determine a periodic review for the care plan. And so this will be a clinical decision either by the practitioner or the clinical staff submitting or working under the supervision of that practitioner. So based on the care plan that you have put together, um, you could decide, I really need to look at this care plan in depth in 3 months, or I need to look at this care plan next year. You need to do at least a yearly review and make sure all the information is the same, medications, all of that kind of stuff. However, again, we're trying to prevent a crisis, and so you want to look at, based on this patient, how often do we need to review this? And then, of course, you want to update as needed. Um, if the patient goes into the emergency room, you're going to update your care, or you could update your care plan based on that information from the emergency room visit. Um, Maybe the patient develops some type of new problem. So you need to update that as necessary. So when needed, you're going to add problems, delete problems that are no longer active, any type of change in the patient condition, and then, of course, information from contacts, either with the patient or other providers involved in that care. And then you're going to share your care plan. The care plan must be shared with the patient, and how you do that is really between you and the patient. Some patients will want a paper copy. Um, some patients will be able to accept it by going in through your patient portal. Some may accept it through a text message, through an email. Obviously, you want to watch for any protected health information, the PHI, or the personally identifiable information, PII, depending on how you're sending that. But it's really how the patient can accept that, and then the ways that you have available to give that to them. For an example, if you don't have a patient portal, then obviously that's not how you're going to share the care plan with the patient. But part of sharing that with the patient is going to be, again, not only what you're doing, but what it is you want them to be doing to increase their health, to increase their quality of life. So it's a combination of kind of a partnership between your office and then between the patient themselves. So share it with the patient. You're also going to be sharing it with any other providers that are involved in the patient care. So for an example, the patient is seeing a cardiologist. Number one, you're going to be gathering information from that cardiologist and then also sharing information back with that cardiologist with the care plan itself. And then we also have others that are listed here. Some examples of this could include um, maybe you're sending the patient to physical therapy, for an example. And so you're sharing the care plan to help that physical therapist see the medical necessity for that and what your goal is for whatever that situation is. It could be that you share a portion, possibly, of the care plan with your patient's permission with the local senior citizen center. Um, this could help the patient or help them understand what the patient needs. Again, you'd have to have your patient's permission to do that, and you would be removing, their Medicare number, any other identifying numbers on that. But and really that's, kind of what it's all about. It's everybody working together for that particular patient. And then the next thing we have in your handout is resources for you. The picture that I have up there on your slide is just the Chronic Care Management Services CMS booklet. And this goes through the information that we have talked about. It also has the procedure codes in it and gives a full description of those procedure codes. We also have provided you a link to a frequently asked questions document by CMS. We have information within our Learning Center, and we have an encore presentation of an overview of CCM. We have an encore presentation of the initiating visit, and then this presentation will go as an encore out in our Learning Center also. We're working toward making a full on-demand course on this, but I don't have it completed yet. So we're leaving those encores out there a little longer than we normally would. We also have YouTube videos out there. We have two that are listed on your slide. One again is the overview. The other is the initiating visit. And then we also have one done by another colleague talking about an Office of Inspector General report where providers were billing the CCM and the CCCM both in the same month, or billing the chronic care management services more frequently than every 30 days. So that YouTube video is out there for you also. So our next slide is some timely topics, and I'm just going to touch on these real briefly. Number one, we have a lot of information within our Learning Center concerning depression screening. And, of course, when we're talking with patients with chronic conditions, depression screening could be part of that, or could be an intervention that you determine needs to be made for the patient. So we have a lot of information available in our Learning Center, in our YouTubes on that. And then also we have, or there's information that CMS wants us to share concerning cognitive assessments and care plans. This is a separate service. This would not be part of your CCM. CMS for 2022 is expecting that this service would be about 50 minutes. For 2023, the final rule indicates this is going to move to 60 minutes. But we do have information available on our website for you to take a look at on that. And so the next thing is we're going to go into our questions. One of my colleagues, Tom Ryan, is going to be reading those off, and then we'll answer that. Before we get into the first question, though, I do want to respond to a pre-submitted question. And the pre-submitted question basically said, when billing, can the clinical staff count time where they discussed all problems or only the chronic problems? And so as we talked about earlier, when you're doing chronic care management, it is not only the chronic conditions that are part of your care plan or part of your care management. It is anything that is going on with that patient. Again, the patient calls up with a new problem, you need to be updating that care plan with that new problem. But the answer to the question is you can include the time spent discussing any of those problems as part of the time for your chronic care management procedure code. So, Tom, do we have questions?
Yes, Ellen, we do. First question from Laura. We had providers receive a denial for G0511 because the patient is enrolled in hospice. Would it still be appropriate to bill this with a GV modifier?
If you're billing for chronic care management, you cannot also bill for um, care plan oversight for patients either receiving home health or receiving hospice services. If the situation is where you're not billing for that care plan oversight, then yes, you would need to use the modifier to show that this is separate from the hospice situation. And I would ask Laura if you would send that question in as a follow-up question also, and then we will include that. I want to get the references and everything for that, and we'll include that within our question and answer document. Good question.
Next question from Megan. Does the diagnosis used for care plan have to match the diagnosis used to bill out for each encounter?
No, it does not. For an example, you may be doing chronic care management for, let's say, diabetes and hypertension, but your evaluation and management service, and let me just throw in there, you still bill for an evaluation and management service. Um, when a patient starts with care plan, it doesn't mean you can't ever do an E&M for them. However, if your E&M is to treat the diabetes as a follow-up, you can include that diagnosis. If it's to treat an infection, you can include that diagnosis. For anything that you're billing to Medicare, you'll just include the most appropriate diagnosis for what you're treating the patient for or why you're doing that particular service. Good question.
All right, next one. Can you clarify, you said a patient can receive CCM and PCM billed by different providers.
That is correct. A provider cannot bill for both CCM and PCM. Dr. Smith cannot bill for both. The patient, however, can receive both. So and again, this is a generalization because CCM and PCM are not restricted by specialties. You don't have to be a primary care to do CCM. However, the primary care physician could be providing the CCM, but the patient has had an exacerbation with their arrhythmia. We'll just use that as an example. And so because of that exacerbation, now that primary care doctor wants the cardiologist to develop a plan for that arrhythmia and deal with that. So the cardiologist is then going to do the PCM. The goal of PCM is that that provider will stabilize that patient and then transfer the patient or transfer the care of that arrhythmia, for example, back to that primary care. However, you are going to have patients where that's not going to happen. And so the patient will continue to receive both CCM and PCM at the same time, but not by the same provider.
All right, next question from Tamara. How can we access the TMF care plan template?
In the handout that we provided to you, we have the link to that website. And I don't think it links directly to the template because I think that's a PDF document, but it links to the section where you can download that template.
Thanks. Irene asked, does the care plan differ for PCM from a specialist perspective?
The only difference for the PCM is that your problem list is going to concentrate on that single high-risk condition. Now, you have to keep in mind that when you have a patient who's receiving CCM services and PCM, they're going to be talking to each other. You know, I mean, the CCM is going to have the care plan that includes the diagnosis that the specialist is taking care of under PCM. And so that specialist then is going to be incorporating his or her information into that care plan. In addition to that, it also goes back the other way that primary care physician is going to be incorporating the appropriate information into that PCM plan. So in answer to the question, a PCM plan is the same and requires all the same things, but it's going to concentrate more on that single high risk condition. Excuse me.
All right. Our next question comes from Patty. And is the care plan provider generated, in other words, documented, or as an RN care manager, is this my responsibility?
It can be either one. Generally speaking, the clinical staff working under the general supervision of the physician are the ones who are doing the care management. Depending on your situation, for new patients or patients not seen within the previous year, there has to be an initiating visit with the practitioner, the billing practitioner. So the practitioner then can start to develop the plan. There is an additional procedure code, and that code is G0506 for a comprehensive assessment and care plan during that initiating visit. However, you don't that physician or practitioner does not necessarily have to complete the plan at that time. The clinical staff can certainly be a part of that. In addition to that, for those patients who are established patients, meaning they don't have to have an initiating visit, then the clinical staff, using the medical records, using conversations with the patient, with the practitioner, can develop that care plan.
Lynn, could I weigh in here also? This is Dr. Vlahakis. So if you think about the way that your practice operates, so much of the time you're having those interactions with your providers. Hey, so-and-so called. These are usually patients everyone in the office knows. They call frequently or they have needs frequently. When you think about what this program is designed to do, it's really supposed to be interdisciplinary. And it's probably behaviors that you already have in an instinctive way, intuitive way in your office already. So much of the time, patients' interactions are going to be with the RN case manager team, but it's going to be very unusual for it not to be supervised in a meaningful way, either because of visits in between with your provider or because of conversations you're having. So think about the way your practice operates normally and really pull from that the model that's already existing.
Thank you, Dr. Vlahakis. We appreciate that. And one of the things that Dr. Vlahakis said is that CCM, for the most part, is really something you do every day for these patients. Um, CCM is a more structured kind of way to do that, to document, to identify the time, and to allow you to get reimbursement for it. You know, as Dr. Vlahakis mentioned, you have patients who are frequent flyers, I call them, and, you know, calling into your office. If you can move those into the CCM structure, then they're still getting great care. You know, you're not decreasing the services you're providing to them, but now you can get paid for it. Thank you, Dr. Vlahakis.
Eleanor, we're ready to move to the next question.
Yes, we are. Thank you.
Okay. Next question is from Megan. We received a denial for a patient that had CCM services on September 30th and again on October 1st, but they were billed in separate months. Do we have to wait a certain amount of time in between billing encounters?
Yes. It has to be at least 30 days apart. And and let me just kind of give you my perspective on this, okay? Your best practice is going to be to bill at the end of the month. And let me tell you why that's a best practice. Number one, both CCM, CCCM, and PCM are all timed-based codes. So you don't want to, submit as soon as you meet, the first qualification of time, because maybe you're going to have more time. So if you kind of hold that billing until the end of the month, then you can capture all of the time and then submit that all on the same claim. So both the initial code and any additional codes are coming in together. And then with those additional codes, you can have additional units of service that you have provided. In addition to that, um, the other problem is that, you know, you indicated here September 30th and then October 1st. Okay, on October 1st, we still have the whole month left over. If the patient condition kind of escalates a little bit, or if the provider, the physician or practitioner, is doing moderate or high complexity medical decision making during the rest of October, that can change your procedure code from the CCM to the CCCM, which is a higher reimbursement, of course. So you want to wait until the end of that month to see exactly what has happened with that patient. But no, you submit on September 30th and October 1st, we will deny the second one, always.
Thanks. Next question. Do you have information on the new chronic management codes G3002 and G3003?
I probably have about the same information that you do. CMS has not manualized the information on chronic pain management yet. I have read through the information within the final rule on that. And so I can tell you a couple of things. Number one, it is a separate pain management service. The second thing I can tell you is that a patient can receive both chronic care management and chronic pain management within the same month. Now, this is all going to go back to your documentation. So, if you're doing CCM for a patient and you spend, 15 minutes or 20 minutes talking to them about their pain, about managing that, as part of CCM, then you would not count that time toward the chronic pain management. And then the same thing holds true. Any time that you count toward chronic pain management, you would not count toward chronic care management. We are waiting, just like you guys are, for CMS to manualize the information within the final rule. Um, and I'm sure that they're going to. And then also, I would anticipate that they will be publishing some type of document similar to the CCM booklet that we showed you, to provide more information on that. But that's all that I know about chronic pain management right now.
All right, let's move on to the next question. And this is a clarifying question. You said the diagnosis sent on the CCM claim does not have to state what DX is that allows patients to qualify for CCM. Example, patient has COPD and CHF, but on the claim, the diagnosis is toenail issues. We only have to put the diagnosis of toenail issues on the claim and not what the chronic care conditions qualify for the patient for CCM.
And the answer to that is a correct statement. Um, when you're submitting CCM or any of these services we've talked about, you have to have a diagnosis, obviously, on the claim that you're submitting to us. Now, in the example that you gave, you could certainly use the toenail diagnosis, and Medicare will process that. Your best practice is going to be to use the chronic conditions diagnosis codes. Again, not required, but best practice. And the reason why it's a best practice is that if CMS is doing a data analysis, as an example, on CCM services, and they're looking at diagnoses that are being submitted, they will not go, oh, wait a minute, if your diagnosis is COPD and chronic heart failure. Whereas if your diagnosis is, an infection of the pinky toe, then they could go, we may need to look at that one further. So while the answer is there's not a requirement that you have to use only the chronic condition diagnosis codes, that is your best practice.
Okay, just a general statement for everybody. This is our last question. So if you have more questions, you want to take the opportunity to put those in now. But our last question is from Megan. We have a provider that has left our organization. To continue CCM services on their patients, are we able to just obtain a verbal consent to change to our current provider? Or are they required to come in and see their new provider before they bill CCM?
Megan, that is a very good question, and I'm going to ask you, and I have an answer for you, but I'm also going to ask you to include that in the follow-up question module, if you would, because I think that's an excellent question for our Q&A document. In the situation that you have Dr. Smith who has left your practice. Okay, Dr. Smith is the one who was supervising the clinical staff and involved in that patient care. So what you want to look at is, do you have another practitioner within that office who is the same specialty as Dr. Smith? If so, and he is going to take over the care of this patient, then yes, you would want to notify the patient of the fact that Dr. Jones is now going to be the one who's going to be treating you. If they are the same specialty, and let me say it this way. If they're the same specialty, look at your consent form. If you used a consent, an actual form, or a written consent, does it state, I consent to Dr. Smith providing CCM, in which case you will want to get another consent that states Dr. Jones. If your documentation of the patient consent says, I consent for ABC Medical Clinic to provide CCM, then you would not need to have one. And then you would make a determination, and Dr. Jones, the new doctor, would make this determination based on the care plan, whether or not he or she needs to see the patient in order to identify any changes to the plan. If he or she does not, it is still an established patient, and therefore he can review that care plan as part of that supervision, and then you would just continue submitting that. If the two physicians are different specialties, then it would be like beginning over again. I mean, obviously, you can keep the information that you had, for that patient previously, but you would have to look at whether or not they require an initiating visit. And then also you would have to have a new patient consent.
We just had a general comment submitted, and I think it's a good one that you might want to go over. They want to know where the Encore will be, and which, again, everyone is why we're recording this, that we will have an Encore. So, Ellen, you might want to go over that again. Other than that, we have no questions.
Okay. Yeah, our Encore presentation will be contained within our Learning Center. And on the last page of your handout, it has the link to the Learning Center. And so once you register in through that, you go into your dashboard to find the Encore. You'll go into the content library and then go into assets. Under assets, you have a drop down. Hang on. Oh, sorry about that. You'll have a drop down that says Encores, and this will be dated either 11/17/22 CCM Care Planning Encore, or it will be 2022 11/17 CCM Care Planning Encore. The handout that we provided to you for the course will also be there, so you can download that at the same time. And then, again, once we update the Q&A document, then we will be putting a new version of that out there also. We will have our follow-up question module open for 2 weeks following this presentation. We'll have it open until the 28th of November. And so following that, the next business day after that, we'll download those follow-up questions, and then our team will start working on updating those Q&A document. And then, of course, we will publish in our e-news when that is updated and when the new version is available. If you're not currently signed up for our e-news, I strongly, strongly encourage you to do that. We send out an e-news on Mondays that has updated information, new information that providers need to know. On Wednesday, we send out our educational e-news that has all of our upcoming webinars and presentations. And then that's where the publication will be when the Encore is available and when the new Q&A document is available. And then we send out one on Thursdays that is a publication of CMSs. It's real easy to sign up for the listserv. You simply go to our website, which is wpsgha.com, and down in the left-hand corner, you can put your email address in there, and then you're signed up for the notifications. We also encourage you to go out and look at the YouTube videos that we've talked about. Like I said, we've got 3 out there on chronic care management. We have a ton of others on all kinds of different subjects out there. We think they're pretty good. But we want you to do a couple of things. You want to register for that so that you receive notifications when we post a new YouTube video. We also, if you like the video, please let us know that and share that video. And then we also want your comments. Putting together a YouTube, it's obviously more than, kind of just taking a selfie and talking to the camera. And so we want to make sure that we're getting the information out there that you want and you need. So leave us a comment. If you liked it, let us know that. If you, think we needed to do something a little different, let us know that also. Again, we're not doing these YouTube videos to make us happy. We're trying to do these to give you information that you need to have. So then the last information, well, Tom, let me ask once more, do we have any additional questions?
We do not have any further questions, but I do want to let everyone know that I did add the URL to the website, the wpsgha.com, down in that chat feature. Also URL to our web address, I apologize, web address to our YouTube channel is available down in the chat feature. So if you want to grab those, save those, but no further questions.
Okay, thank you, Tom. I appreciate you doing that. And just as an FYI for everyone, Tom did one of the YouTube videos, the one that talked about the Office of the Inspector General results. And I think you'll find it very interesting when you go out and look at that. So the next information I want to provide to you then is just about completing the course. You have 10 days in order to complete it. The information up there on your screen lets you know that we will receive a report from our vendor from WebEx, probably sometime before the end of the afternoon. And then we will be going into our learning center to mark everyone as complete. Once we do that, you'll receive an email. And then once you receive that email, you'll be able to go back in, take the post assessment, and then do the survey. As I stated earlier, we really want to hear from you. I know surveys are aggravating. You know, we get pop-ups on our computers and stuff all the time. However, for WPS, CMS has noticed that our number of responses on the survey has been declining. So we want to turn that around. And then, as I stated earlier, CMS pays attention to the responses, and WPS pays attention to the responses. You know, if you're not able to rate us at this presentation at the highest rating, tell us why. We really want to know your thoughts and your feelings on this so that we can improve based on your comments. You know, so please take that survey. It doesn't take very long, just a few minutes, and we would really appreciate that. And then once you receive that email, again, we talked about the post assessment will open. You will also have the follow-up question module will open. Now, in your handout, there's a who attended that is listed. We have removed that one. For the most part, everyone is dialing in or accessing the webinar on their own computers. If you have had someone listening with you or watching with you, then you can send an email to our wps.gha.education@wpsic.com to let us know who was viewing this with you on the same computer. Tom, thank you, Tom. I knew you'd be right on that. And so again, you know, you have until the 28th to complete this. So Tom, I'll ask just one more time. Do we have any additional questions?
We do not have any additional questions.
Okay. All right. Thank you guys very much for your attendance today. We really appreciate that. And this will end our webinar for today. Thank you guys.